This is a review of pain keywords that are commonly asked or missed on the in-training exam. Topics we're going to cover today include cancer pain, plexus blocks, basic physiology of pain and pain pathways, postherpetc neuralgia, acute herpes zoster, as well as complex regional pain syndrome type 1 and type 2. In discussion about the basic physiology of pain and pain pathways, everything starts with a stimulus. We'll say the star is a stimulus. Stimulus can be mechanical, thermal, or chemical. And through a process of transduction, the nociceptors, or also known as pain receptors, turn the stimulus into electrical activity. Most nociceptors in the human body are free nerve endings that respond to pain, temperature changes. Some receptors respond to deep pressure or tissue injury or chemical irritation. So once the stimulus occurs, it's going to then, once the stimuli is converted into electrical activity via action potential, the stimulus travels via a primary afferent neuron, which are going to be A delta and C fibers, to the spinal cord and synapse on a secondary order neuron, and then is going to lead to a tertiary order neuron, which is in higher structures of the brain, such as the thalamus, and ultimately lead to the cerebral cortex or some other cortical areas for processing of this information. So the process after transduction occurs is transmission, and transmission essentially means that signal is being sent from the periphery to the spinal cord to the brain via the peripheral nerves, being the primary afferent neurons, and then secondary afferent neurons that are located in the spinal cord are of two types, wide dynamic range neurons and nociceptive specific neurons. So primary afferent neurons, these neurons start with the receptor, they travel in the periphery. Their cell bodies are housed in what's called the dorsal root ganglia, and then these synapse into the spinal cord. The dorsal root ganglia is located usually in the foramen or right within the spinal canal. And these are pseudounipolar neurons, and these are the little cell bodies. Of note, the primary afferent neurons are of two different types, A delta, C, as well as B fibers. So these differ in their size and myelination status. So A delta are going to be lightly myelinated, larger neurons, and C fibers are going to be unmyelinated neurons, and these are the type of fibers and neurons that transmit pain. B fibers are lightly myelinated neurons, and these are what's thought to transmit visceral related pain. So the function of this, if you look at the graph on the right of the screen, we have both A delta fibers and C fibers. So if you stub your toe We all know what that feels like. You get this first very sharp, intense pain that reaches our brain quickly, and we know what we have just done. So this is the signal. It's sharp pain. It's the first pain, and if you've done it before, you anticipate this later stage, this burning, dull, poorly localized, intense pain that's going to come. And that is going to be your C fibers, because the time it takes for that signal to reach the brain is longer, as these travel 2 meters per second versus 5 to 20 meters per second with A delta fibers. C fibers are the most prevalent. These fibers are about 75% of our pain fibers in the body. Now we're getting into where these primary afferent neurons synapse. So stimulus, primary afferent neuron, dorsal root ganglia, so DRG, into the spinal cord. And a part of the spinal cord, which is known as the dorsal horn. The dorsal horn is subdivided in certain layers, and these layers are also known as rexid lamina. It's important to note that different rexid lamina have different names. So lamina 1 is your marginal layer. Lamina 2 is the substantia gelatinosa. Lamina 3 through 6 is your nucleus proprius. And so this is the sensory part of the rexid lamina. Now, the anterior part of the spinal cord has motor lamina, which are not going to be discussed, but to note that the 3 different lamina that your pain fibers terminate on are 1, 2, and 5. This is a good chart to remember. This is the different laminae or rexid laminae of the spinal cord. You can see rexid lamina 1, also known as the marginal layer, has a pretty high density of A delta fibers. So this is going to give you kind of the fast pain and temperature that reaches the brain. Layer 2 is known as a substantia gelatinosa. It's going to be a higher density of C fibers there. And as we say, with C fibers, they're unmyelinated, so it's going to be more of the slow pain processing. Lamina 5, the nucleus proprius, or part of the nucleus proprius, is going to have both fibers in there. And then this is also where we said our general visceral afferent or visceral pain fibers also terminate. This is an important thing to note. When these primary afferent neurons come into the spinal cord, they don't necessarily synapse at that level. They can actually travel up or down. Some say 0 to 6 segments before they actually synapse on their corresponding secondary order neuron. And this is known as Lissauer's tract. This is important in some more advanced interventional pain therapies such as dorsal root ganglion stimulation. So transmission from the spinal cord to the higher centers, cortical structures. If we kind of start drawing this out here, stimulus, receptor, DRG, spinal cord. They synapse on secondary order neurons, and there are two types as previously discussed. Wide dynamic range neurons, which are the most prevalent, and nociceptive specific neurons. So wide dynamic range neurons are the most prevalent, and they are named wide dynamic range because they can receive various inputs other than nociception. They can receive inputs from A beta fibers, A delta, and C, and they correspond to also a different intensity of stimuli as well, and they are responsible for the phenomenon of referred pain. Nociceptive specific neurons, these, as the name states, specifically nociception. So from these secondary order neurons, they travel from the dorsal horn and their corresponding rexid lamina across the spinal cord, and this tract crossing the spinal cord is known as the anterior commissure. So this is anterior commissure. And then they start traveling up in a specific pathway, also known as the anterior lateral or the spinal thalamic tract or pathway. And this is where pain, temperature, and crude touch is transmitted. And these secondary order neurons, as we said, wide dynamic range and nociceptive neurons, synapse in certain areas of the brain, particularly the thalamus, known as certain nuclei, the ventral posterior lateral nucleus, the ventral posterior medial nucleus of the thalamus, which is primarily the wide dynamic range neurons, and the ventral medial pars oralis, which is where most of the nociceptive specific neurons synapse. So this is the thalamus of the brain. This is starting to put everything together. So if we think again, we start in the periphery with nociceptors in the skin. So there's a stimulus. Through a process of transduction, the signal travels via C fibers and A delta fibers to the spinal cord, with cell bodies being housed in the dorsal root ganglia. They synapse in the spinal cord and rexid lamina 1, 2, and 5. Onto secondary order neurons. So this is primary. These are secondary. And our secondary order neurons are wide dynamic range, nociceptive specific. They travel across the spinal cord via the anterior commissure into the spinal thalamic tract. They travel up to the brain, to the thalamus, where they then synapse in the VPL, VPM nuclei, as well as the ventral medial pars oralis nuclei. So of note, the spinal thalamic tract can be subdivided into the lateral spinal thalamic tract, which is this one. And this is what transmits pain and temperature. This is also known as the paleo-spinal thalamic tract. It's thought to be an older part of the nervous system. And a lot of these fibers, up to 85% of these fibers, transmit on the reticular formation of the brain, and the rest synapse on thalamic structures. The reticular formation is involved in many functions, of one involving the reticular activating system, which is involved in arousal and wakefulness. There's also subdivision called the anterior spinal thalamic tract. Its other name is the neo-trigeminal thalamic tract. And this is what transmits crude touch and pressure. Most of these synapse in the VPL and then go to higher cortical structures, primarily the posterior somatosensory cortex. In the paleospinal thalamic tract, a lot of these fibers synapse in different areas of the brain, anterior cingulate cortex, as well as the somatosensory cortex. This is putting everything together. I would recommend just studying this slide. It's very informative, kind of has everything we've talked about in quite detail. And we've already touched on this, but of note, from the thalamus of the brain and its corresponding nuclei, these then go to different areas of the brain for conscious perception. And some of these areas are the postcentral gyrus of the cerebral cortex, the somatosensory cortex, the anterior cingulate cortex or gyrus, and limbic system. And this is where a lot of the processing, the emotional involvement of pain, as pain is defined as an emotional experience, take place. Moving on to plexus blocks. There are many plexus or neural plexuses in the body, which can be blocked for various indications, such as regional anesthesia or certain non-cancer related pain. This lecture is going to focus primarily on plexus blocks in their role in cancer pain management. There are 4 major plexus that we consider for interventional treatment in the setting of cancer pain. One is the celiac plexus, the superior hypogastric plexus, the ganglion impar, as well as the inferior hypogastric plexus. The celiac plexus is going to be primarily for abdominal cancers, primarily mostly studied in pancreatic cancer. The superior hypogastric plexus block is for pain or cancer in the pelvic viscera, such as uterine carcinoma. Ganglion Impar block or neurolysis is the treatment of visceral pain from rectal cancer. The inferior hypogastric plexus block is somewhere in between pain coming from in between these two structures, or potentially both. So it's important to know visceral pain pathways. The afferent fibers are known as general visceral afferents. These carry pain and reflex sensations from the internal organs to the central nervous system. These fibers travel along with autonomic nervous system fibers, either the sympathetic or parasympathetic. And these are essentially the target for neurolytic procedures or the block procedures. If you look at the diagram on the right, 6 and 7 are your autonomic nervous system fibers. And actually, these are technically efferent if they're coming from the autonomic system, and afferent if they're transmitting sensory signal. And so you can see 6 and 7. 7 we'll say is a general visceral afferent that comes in from the abdomen into the sympathetic ganglia through the white rami communicans to the dorsal root ganglia and then into the spinal cord and then up. The efferent system, known as the autonomic nervous system, sympathetic or parasympathetic, travels along with them. And so these bundle of neurons travel together. This is a diagram of your autonomic nervous system. We remember from medical school, parasympathetic, cranial, sacral. Sympathetic, thoracolumbar. And that's where these fibers originate in the spinal cord, and these are efferent fibers. But as discussed, the general visceral afferent fibers, your sensory and pain fibers of visceral structures, travel along with the autonomic nervous system. For example, say we have pancreatic cancer. Your general visceral afferent is going to run with a sympathetic fiber. It's going to synapse on the celiac plexus. It's then going to travel to the sympathetic ganglia via splanchnic nerves and then to the spinal cord. And then up towards the brain for higher processing. One important thing to know is that visceral pain can be perceived as somatic pain over dermatomal regions that are in the same area. For example, if someone is having a myocardial infarction, they may experience chest pain, but they may also experience arm pain. And this is what is a phenomenon known as visceral somatic convergence or visceral referred pain, where the fibers enter in a certain area in the spinal cord. In this example, upper thoracic, which may be felt in a dermatome, myotome, or osteotome in the left arm. An important concept to know with visceral pain are pain lines. There are two pain lines, thoracic pain line and pelvic pain line. And as we remember, the parasympathetic nervous system is cranial, sacral, the sympathetic is thoracolumbar. So any visceral organ that is subperitoneal, which means it is not in contact with the peritoneum, these pain fibers, the general visceral afferent fibers that are subperitoneal, travel via pelvic splanchnic nerves through the parasympathetic pathway. So for example, anything below this green line here is below peritoneum. And so these general visceral afferents travel with parasympathetic fibers. Anything above peritoneum, uterus, top of the bladder, these travel with the sympathetic nervous system. Now there are two exclusions, the distal sigmoid colon and rectum, and those are believed to travel with the parasympathetic fibers even though they do come in contact with peritoneum. This is a drawing from Netter's with the same anatomy. So we have a visceral organ, these general visceral afferents, which are represented by the black line, travel in a synapse and certain ganglia. And these targets for Plexus blocks are the celiac ganglia, the superior hypogastric plexus, the inferior hypogastric plexus, and the ganglion impar, which is the caudalmost ganglia of the sympathetic nervous system. After these fibers synapse in their corresponding plexi or ganglia, they travel to the spinal cord via splanchnic nerves. So from the celiac ganglia to the spinal cord, they travel via thoracic splanchnic nerves, which have three divisions, the greater, lesser, and least. In different parts of the abdomen, there are lumbar splanchnic nerves and then sacral splanchnic nerves that travel with the sympathetic nervous system. There's also pelvic splanchnic nerves at the bottom here, where parasympathetic and general visceral afferents travel with the parasympathetic fibers. Just again, same concept, similar picture, male anatomy. The green here is the inferior extent of the peritoneum. Also, we remember the pelvic pain line. And if you look closely at the black lines, which are the general visceral afferents, it gives us an idea of which plexus block would be more efficacious depending on which organ is involved. Same thing in a female, the inferior extent of the peritoneum. So if you have uterine cancer, you may benefit from a superior hypogastric plexus block. If you have cervical cancer, you may benefit from an inferior hypogastric plexus block. These are essentially kind of what it looks like from a gross view. Your celiac plexus is at the T12L1 level, and it's anterior to the aorta. The lumbar sympathetic plexus is at the L2, L3 level, which is not something we would typically block for cancer-related pain, but we do treat CRPS of the lower extremity with the block here. Celiac plexus is going to cover most abdominal structures. The superior hypogastric plexus block is going to be the majority of the pelvic cavity and structures that are in contact with the peritoneum. Below that, the inferior hypogastric plexus block are going to be either structures below peritoneum or a mixture between below and above peritoneum. And then the ganglion impar, this is primarily for rectal cancer. Celiac plexus block and neurolysis. This is for abdominal tumors that are innervated by the thoracic splanchnic nerves, which corresponds with the upper thoracic T5, T12 area of the spinal cord. It's made up of 3 different nerves, the greater, the lesser, and the least, that all come together. They synapse onto the celiac plexus, which is anterior to the aorta. These innervate the majority of the abdominal cavity, and the indications for this are cancers of the abdominal cavity, primarily pancreatic cancer. There's several different approaches to this procedure. So there's a retrocrural approach, which just means you're behind the diaphragm. This is also known as a splanchnic block. And if you kind of look up here, this would be medication deposited for a splanchnic block, or the retrocrural approach, as you're getting the greater, lesser, and least splanchnic nerves. There's the anterior crural approach, where your needle tip is at the level of L1 and it's just slightly anterior to the diaphragm. You can see the diaphragm here. And where your medication is deposited in that area. And it goes ideally around the splanchnic nerves and getting some of the celiac plexus as well. We typically start these blocks on the left side. In the case that we accidentally get into the vessel or a vessel, we then convert this anterior crural approach into a transaortic approach, which means that if the aorta is here, and we get a needle in, we start aspirating blood, we push our needle all the way to the point where we no longer aspirate blood, meaning that we're on the anterior ventral side of the aorta. So kind of, as you can see here. And then we inject contrast medicine and our local anesthetic and potentially neurolytic agent. There's other approaches. There's an anterior approach, there's an endoscopic approach that some of the GI doctors do, but those will not be discussed. This is essentially what we see when doing a celiac plexus block. We have the patient in a prone position. We identify the L1 vertebral body. We square off the superior end plate of the L1 vertebral body. We oblique our fluoroscope over to where the transverse process is overlying the side of the vertebral body. This gives us the angle that we need. And normally we will stop around right here for a retrocrural or splanchnic nerve block approach. Occasionally, if we don't get good spread, we can push the needle a little bit further and try for an anterior crural approach. If by chance we aspirate blood, you then can convert to a transaortic approach, which is what this picture is, where contrast dye medicine is deposited on the ventral surface of the aorta where the celiac ganglion is present. And as we know, Celiac ganglia is here. Your splanchnic nerves start traveling up in this area. So as long as your medication blocks this pathway somewhere, you should have a good effect. So complications from this procedure, most commonly you're going to see diarrhea or orthostatic hypotension. The reason is because in this block, we're blocking both the general-visceral afferents, but we're also blocking sympathetic nerve fibers. If you cause a sympathectomy, you're going to get vasodilation. And with vasodilation, you can get orthostatic hypotension. If you block the sympathetics, you're going to have unopposed parasympathetic, and which can cause diarrhea, rest and digest. Back pain is quite common from this. It's usually referred back pain, especially if you use a neurolytic agent. Dysesthesias can occur because the alcohol or phenol can demyelinate. That's essentially what they do. They demyelinate the neurons and can cause axonal injury, which can cause these dysesthesias. So transient or permanent motor paralysis can occur, and this would be concerning that the medication is leaked back near the spinal nerve roots, but most importantly, we make sure the best that we can that the medication stays away from the spinal cord, particularly if we're injecting our neurolytic agents, which is ethanol and occasionally phenol, but most of the time we use ethanol. Hematuria can happen as the kidney is one structure that the needle can pass through. Retroperitoneal hemorrhage can occur both by the transaortic approach, but also even if you're doing a retrocrural approach and you do the left side and then the right side, if by chance the needle gets in the inferior vena cava on the right side, it can lead to retroperitoneal hematoma. The aorta is a big muscular structure, and so the wall can close off quite quickly. The vena cava is not muscular, so if you poke a hole, it's likely to continue to bleed. Aortic dissection is possible. You also could flicker off any aortic plaques if you do a transaortic approach, which is why it's very important to look at your CT scans before doing this procedure. So this is the technique for superior hypogastric plexus block. Typically we do a transdiscal approach at L5-S1. Our fluoroscope is obliqued over. The superior end plate of L5 is squared off, typically with cranial tilt. The needle is either passed through the disc, or sometimes occasionally we can go on the side of the disc and we block this plexus of nerves known as the superior hypogastric plexus, primarily for uterine cancers or cancers of the pelvic cavity. This is an example, the neurolytic approach for uterine cancer. As you can see, the needle is traveling through the L5-S1 disc, and the medication is being deposited on the anterior side of L5 and S1. So for some of you all who haven't rotated through interventional pain, this is L5, this is S1, and your plexus is in this area. And the plexus branches off into the hypogastric nerves, so left and right hypogastric nerves. This is ganglion Impar block. This is done a couple different techniques. You can go through the sacrococcygeal disc or ligament, which is what is depicted in this picture here. There are some approaches where you can actually go underneath the coccyx and up, and this blocks the ganglion impar, which, as I said, is the most inferior extent of the sympathetic chain. Sympathetic chain on both sides actually connects at the bottom, and this is for rectal cancer. Most likely, what we're actually blocking here is the inferior hypogastric plexus, which contains afferent fibers from the pelvic splanchnic nerves. So on to a different topic, herpes zoster, also known as shingles. So people that have had a prior infection with the varicella zoster virus, known as chickenpox, this virus will then evade our immune system by moving into sensory ganglia, notably the dorsal root ganglia, or sometimes the trigeminal or other facial nuclei ganglia. They can hide out in there for years and then reactivate at some point. So reactivation of varicella zoster virus causes the disease that we know as shingles. There's usually some prodromal symptoms that occur first: headache, fever, malaise. Sometimes you can get some abnormal skin sensations. So the virus is starting to replicate. It's starting to replicate inside the DRG or other ganglia, such as the trigeminal ganglia, and it'll start traveling down these sensory nerves to the skin, where then the virus affects skin cells, which is causing vesicular lesions with pain, burning, itching, and this is the virus shedding. There's a lot of pain as there's nerve damage that is occurring, radicular neuritis. So this vesicular maculopapular rash crusts over after a couple weeks, and usually the disease process is over at that point. So risk factors for shingles: anything that decreases your immune system or cell-mediated immunity. So older age, HIV infection, cancer, immunosuppression therapy. The incidence in the U.S. is approximately 500,000 cases per year, or 2 cases per 1,000 persons. The lifetime risk is 10 to 20%. As we get older, the risk increases. So if you're older than 85 years old, 50% of people would have at least one episode of herpes zoster. This is a picture format. So you get chickenpox, usually as a kid. Virus comes in, finds our nervous system, travels down these nerves, goes into the dorsal root ganglia, hides out. Years down the road, our immune system gets suppressed for some reason. This virus starts activating again as our cell-mediated immunity is decreased and starts replicating, travels out these sensory nerves to the skin, and is what causes zoster. This is a person that has an acute herpes zoster flare. This looks like probably a T3 or T2 dermatomal lesion on the right side. This can occur anywhere in the body. You typically see thoracic or lumbar, but you can also see it occurring in the face, in the trigeminal, the trigeminal nucleus, so the ophthalmic, maxillary, and mandibular branches, and it can involve 1, 2, or all 3 of those branches. And many times when we see patients in clinic, they actually have a multi-dermatomal distribution. So on the left here, we have a patient that has V1 ophthalmic distribution of shingles. This is pretty serious as it can cause blindness, it can scar the cornea. On the right here, we have a condition known as Ramsay-Hunt syndrome. And this is when shingles involves the geniculate nucleus of the facial nerve. And you see certain symptoms. A vesicular rash on the external ear. You have lower motor neuron palsy of the facial nerve, kind of looks like Bell's palsy. And you lose taste sensation of the anterior 2/3 of the tongue. Some definitions. So acute herpetic neuralgia, so essentially shingles. That's pain and rash that persist up to about 30 days from its onset. Subacute herpetic neuralgia, this is pain that persists beyond the healing of the rash, but usually resolves within about 4 months or so. Postherpetc neuralgia, we say this definition for people that have pain after the rash has resolved somewhere greater than 4 to 6 months. And this is usually from, neuronal damage. Treatment for somebody with shingles or acute herpes zoster, so antiviral medicines. They work by viral DNA, inhibition of viral DNA replication. So we know that if you start them within 72 hours of disease onset, they are effective at decreasing the severity of acute pain, the acute disease, and they shorten the viral shedding period. Efficacy, there's 3 different types that are used: valacyclovir or Valtrex or famciclovir. Those are thought to be more efficacious than acyclovir. There's no strict guidelines for treating the pain of shingles. NSAIDs, steroids, Tylenol, TCAs, anti-epileptic drugs, sometimes opioid pain medications. So antiviral therapy, so say Valtrex with steroids, has been shown to improve acute herpes zoster pain and quality of life, but oral corticosteroids do not prevent this leading into postherpetic neuralgia. There's some evidence to suggest that sympathetic blocks or epidural catheters can reduce and prevent the development of postherpetic neuralgia, as well as reducing acute herpes zoster pain and duration of the rash. The mechanism behind this for sympathetic block, it's thought that in the sensory ganglia or dorsal root ganglia, there's a severe ganglionitis that occurs, so severe inflammation and neuritis, which leads to a profound sympathetic response, which leads to vasoconstriction, neural ischemia, and eventual cell death. And by blocking the sympathetic ganglia early on, you may be attenuating this vasospasm and preventing irreversible damage. It's a similar mechanism with epidural local anesthetics or transforaminal epidural steroid injections to reduce the inflammatory response. Postherpetic neuralgia, again, this is for people that have had shingles that have pain that has persisted beyond 4 to 6 months. About 10 to 20% of people with shingles will develop this. Incidence increases with age. It's pretty rare for people less than 40 years old. So risk factors we know are age, the greater severity of rash, female gender, and greater acute pain severity. Prevention. So this vaccine came out in 1995. This is the Visceral vaccine. It's a 2-dose live attenuated vaccine. It has a reduction in the incidence of chickenpox by 90 to 95% in children's age 1 through 9. The thought is that if you can eliminate the initial varicella infection, that you will not develop shingles in the future. This is a live attenuated virus vaccine. They do not believe that this can establish latency like the wild type Visceral Zoster virus. So prevention, Shingrix is the newer shingles vaccine. There was an older vaccine known as Zostavax. So currently the CDC recommends healthy adults age 50 or older to get 2 doses of the Shingrix recombinant zoster vaccine, separated by 2 to 6 months to prevent shingles or complications from it. It has a strong protection against both shingles and postherpetc neuralgia, 2 doses being more than 90% effective at preventing shingles and postherpetc neuralgia. And this protection stays above 85% for at least the first 4 years after you get vaccinated. You should get vaccinated even if you've had shingles. If you have had the older vaccine, the Zostavax vaccine, even if you're not sure you've had chickenpox. There's no maximum age. For people that have had shingles in the past, you can get the Shingrix to prevent future occurrences. And there's no specific length of time that you need to wait after having shingles before you can receive this vaccine. But in general, you want to wait for the rash to go away. On to complex regional pain syndrome. So this is a pain syndrome that occurs after an inciting event that causes tissue injury in the upper or lower extremities. It's divided into 2 subtypes. CRPS type 1, formerly known as reflex sympathetic dystrophy. Type 1, or where there is no known nerve damage. Type 2, formerly known as causalgia, is where the inciting event causes clear nerve damage, such as accidental or purposeful surgical nerve ligation or transection. There are no differences in the clinical manifestation between these 2 types. Some of the clinical things that we see are allodynia, that is pain that results from a non-painful stimuli, such as light touch causing severe pain. Or hyperalgesia, this is pain that is out of proportion than that is what is expected from a painful stimulus. There is sympathetically maintained or mediated pain. This is a type of pain that was once thought to be maintained by sympathetic efferent output or circulating catecholamines, but the current school of thought this might not necessarily be what is occurring in these pain syndromes. Clinical features, so sensory changes, as discussed, allodynia and hyperalgesia. Vasomotor changes, so these include things such as the extremity being warm or cold, or color changes. Pseudomotor changes, where you can have swelling, edema, or increase or decrease sweat pattern. Motor or trophic changes, where you can have decreased range of motion or stiffness, weakness, or changes in the skin, hair, and nails. So diagnostic criteria for CRPS. So this is a clinical diagnosis. The first thing you have to do is rule out other causes of pain. There is what is known as the Budapest criteria, and this was a criteria that one of the pain societies, when they met in Budapest, created to help diagnose this syndrome. So according to the Budapest criteria, the patient must have continuing pain that is disproportionate to the inciting event. There must be no other cause. Patient must have one sign in 2 or more of the categories below, and one symptom in 3 or more of the categories below. These categories we discussed on the previous slide. So sensory, vasomotor, pseudomotor, motor, or trophic. So one sign in 2 categories, and one symptom in 3 categories. So bone scans, they don't really have a whole lot of utility in diagnosing this condition as it's a clinical diagnosis, but you can certainly see some bone turnover in these patients. But one thing to be careful of is that you can see bone turnover in many other diseases, particularly certain types of inflammatory arthritis. We don't normally order this study for our patients as it has low yield and doesn't really change our management. CRPS used to be taught in 3 different phases. It doesn't necessarily occur like this, but this was a kind of a former school of thought. So there's this hot phase that's within the first 6 months where you have a painful, warm, red, sweaty, swollen extremity, which they thought then progressed in, the second 6 to 12 months to a cold, cyanotic, mottled extremity. This is known as the dystrophic or cool phase. And then this atrophic phase where the disease occurs longer than a year and the extremity becomes cool, skin is thin, the muscle starts to atrophy. Don't really see it clinically in these time phases, and some people never necessarily have muscle atrophy, but they can present with any type of these pictures. And these are some pictures of CRPS. Probably early for the folks on the left. This is pretty swollen red extremity. Again here, kind of red bluish color as compared to the left hand. And the patient on the right side of the screen looks like is having pretty severe, as we're starting to have some fingernail changes, some atrophy of the muscles, and some stiffness, swelling, and redness.